So what is the cause of this dumping syndrome? It is caused by accelerated emptying or dumping. So it is caused by accelerated emptying, or dumping of hyperosmolar content. So there is dumping of what? Hyperosmolar content into proximal part of small intestine. So dumping of hyperosmolar content, hyperosmolar content into the proximal part of small intestine. Clear? After that, patient is going to develop constellation of symptoms. So we discussed that it is more common in Billroth 2 or Billroth 1. So obviously it is more common in Billroth 2. So this is more common in Billroth 2. Clear? It is divided into two types, early dumping and late dumping. See the differences. Now this early dumping, it is seen within 15 to 30 minutes of meals. Now see, whenever you're going to eat the food, suppose there is Billroth 2 gastrectomy. So what happens? This hyperosmolar content enters into proximal part of jejunum. It is going to irritate jejunum. So what happens? There is increased secretion from jejunum. And what happens? 2 to 3 liters of fluid will be collected into the lumen of small intestine. So from where this fluid has come, actually there is third space loss. So there is migration of fluid from vascular compartment into extravascular compartment. So ultimately what happens in early dumping, these patients are going to develop hypovolemia. So what is the problem here? In early dumping, it is seen within 15 to 30 minutes of meals. Seen within 15 to 30 minutes of meals. 15 to 30 minutes of meals. Clear? And what are the sequence of events here? Here, the problem that there is presence of hyperosmolar content. Where exactly? Into the proximal part of small intestine. So there is presence of hyperosmolar content. Clear? In jejunum, means in the proximal part of small intestine. And because of that, what happens? From the jejunum, there is increased secretion. So what happens? There is increased secretion in the jejunum. And because of increased secretion, what happens? The fluid is coming from vascular compartment going into extravascular compartment. So you know that this is third space loss. So because of increased secretion, patient develops hypovolemia. This is third space loss. Clear? So ultimately patient develops hypovolemia. Hypovolemia. Now see the situation. Suppose this patient is having dinner with you at dinner table. What you're going to notice that after 30 minutes of meals, patient disappeared. So what happened? Patient collapsed under the table. Now patient is under the table. So what you have to do? You have to lie this patient supine and you have to give IV fluids to the patients. Why? Patient developed hypovolemia. So how we are going to manage these patients? In these patients, since there is hypovolemia, so we have to give IV fluids. So what? IV fluids should be given. In early dumping, late dumping, it is seen after 2 to 3 hours of meals. So late dumping, this is seen after 2 to 3 hours of meals. After 2 to 3 hours of meals. 2 to 3 hours of meals. Now here what's the problem? See, the hyperglycemic content is there in the jejunum. Because of this hyperglycemic content in the jejunum, there is increased release of insulin. And because of increased insulin release, what happens? There is reactive hypoglycemia. This term you have to remember because this term is asked. Increased insulin release causes reactive hypoglycemia. So since patient develops hypoglycemia, what you have to give? Oral glucose. So what is the problem here? There is hyperglycemic content. So in these patients, there is hyperglycemic content. Where is the hyperglycemic content? So hyperglycemic content in jejunum. Clear? So there is hyperglycemic content in jejunum. Because of that, there is increased insulin release. So there is increased insulin release. Clear? And because of increased insulin release, patient is having this term you have to remember, reactive hypoglycemia. So there is what? The patient is going to develop reactive hypoglycemia. This question was asked in exam. That what is the cause of early dumping? Early dumping, it is because of hypovolemia. And what is the cause of late dumping? It is because of reactive hypoglycemia. So how you are going to manage? Yes, we have to give oral glucose. Since patient is having hypoglycemia, we have to give oral glucose. Clear? So for dumping syndrome, it is said that prevention is better than cure. How we are going to prevent the dumping? First of all, dietary modification. We ask the patient that don't eat too much in the first go. So what you have to take? Small frequent meals. Now you tell me, which food stuff is responsible for most of the problems in dumping syndrome? Yes, carbohydrate. So we have to reduce the carbohydrate intake. So it should be low carbohydrate, high fat, high protein diet. What patient has to avoid? High calorie drink. Because what happens is a liquid, so with force it is going to enter into the, because it is going to follow the gravity. So what happens? It is going to enter into the jejunum. So patient should avoid high calorie drink, and during meals patient should avoid liquids. Why? Because if patient is going to take excessive liquid, what happens? It is going to push the food distally. So see the prevention. So the first is dietary modification, small frequent meals. This question was asked. There should be low carbohydrate, high fat, high protein diet. Patients should avoid high calorie drinks and avoid liquids during meals. What happens? Most of the patients are going to improve after dietary modification. If patient is not improving after dietary modification, in these cases we have to give octreotide. Suppose there is no improvement, so in such cases we give octreotide. Why? What is the role of octreotide? Yes, you know that octreotide is somatostatin analog, and you know that somatostatin is considered as universal switch off. Why it is considered as universal switch off? Because it is going to switch off most of the GI secretions. Similarly, what is the role of octreotide? It is going to decrease GI secretions as well as insulin release. So what's the role? It is going to decrease GI secretions, GI secretions as well as insulin release. It is going to decrease insulin release. So going to decrease GI secretions as well as insulin release. Clear? So that's why you can see GI secretions means obviously it is going to improve the early dumping. Insulin release means late dumping. So majority of patients are going to improve after octreotide. There is very little percentage of patients who are not going to improve, and in those cases we have last resort, that is surgery. So suppose still patient is not improving, in these cases we go for surgery. We discussed that dumping syndrome, it is more common in Billroth too. So what we can try? We can try to convert Billroth 2 into Billroth 1. Try to convert Billroth 2 into Billroth 1, though it's not very helpful. Surgical options are not going to provide permanent cure. So it has been seen that even after surgery, patients are still symptomatic. Second option, that we can go for interposition of anti-peristaltic segment of jejunum. What? We can go for interposition of anti-peristaltic segment of jejunum. Clear? What is this anti-peristaltic segment of jejunum? Interposition of anti-peristaltic segment of jejunum. Tell me, what is this anti-peristaltic segment of jejunum? It's very easy to understand. Imagine this is the patient in whom this kind of reconstruction has been done. Billroth 2 reconstruction has been done. Clear? What is the direction of peristalsis here in the jejunum? You can see the direction of peristalsis in the jejunum. It is like this, antegrade. Okay. What you do, you just remove it. So try to cut this part. So what I'm going to cut this part of jejunum. So I have removed this part of jejunum. Clear? So when I just remove this part of jejunum, now see the final picture. This part of jejunum is removed. Clear? After removing this part of jejunum, can you tell me what was the direction? The direction of peristalsis was something like this. This was the direction of peristalsis. Clear? Now what you do, you just reverse it. Reverse it. So if you reverse it, So if you reverse it, what happens? Now the direction of peristalsis is like this. Okay, this segment is isoperistaltic and this one is antiperistaltic. Now what you do, you perform the interposition of this antiperistaltic segment. So I'm going to perform the interposition of this antiperistaltic segment. So what is the direction of peristalsis in this antiperistaltic segment? In opposite direction to rest of the bowel. So it is going to try to hold the food for longer duration, though not very helpful. So what this is? Interposition of anti-peristaltic segment of jejunum. So these are the management options for dumping syndrome. Now see the metabolic complications. What is the most common metabolic complication of gastrectomy? Iron deficiency anemia. The most common metabolic complication of gastrectomy, that is iron deficiency anemia. Iron deficiency anemia. This is frequently asked question. Iron deficiency anemia. This is the most common metabolic complication. This is the most common metabolic complication after gastrectomy. Clear? So this is the most common metabolic complication after gastrectomy. Question why? What is the problem? Whatever the iron you take, the oral form of iron, that is Fe3 plus. On this Fe3 plus form, there is action of acid and this is converted into Fe2 plus. This Fe2 plus is absorbable form of iron. See the problem here? We take iron in Fe3 plus form. After that, there is action of acid. So there is action of acid, and after that it is converted into Fe2 plus. Fe2 plus form. This Fe2 plus form, this one is absorbable form. So 3 plus, this is oral form. 2 plus, this is absorbable form. This is absorbable form. If we perform gastrectomy, so what happens? One of the function of stomach is to secrete acid. So if there is lesser secretion of acid, what happens? Lesser conversion of Fe3 plus into Fe2 plus. So patients are going to develop iron deficiency anemia. How to manage? It's easy. We have to increase the oral supplementation. So what's the management of this iron deficiency anemia? Here we give management increased oral supplementation. So we have to give increased oral supplementation. Increased oral supplementation. Clear? Now there is a second option. What? Sometimes when more than 50% of stomach is removed in these patients, there is deficiency of intrinsic factor. What's the role of intrinsic factor? Intrinsic factor helps in B12 absorption from terminal ileum. So if there is no intrinsic factor or deficiency of intrinsic factor, obviously patients will be developing megaloblastic anemia. So all patients of gastrectomy are not going to develop megaloblastic anemia. How much stomach should be removed? When more than 50% of stomach is removed. So second complication, megaloblastic anemia. The second complication is megaloblastic anemia. Clear? And this megaloblastic anemia is seen in the patients in whom more than 50% of stomach is removed. When more than 50% stomach. So when more than 50% stomach is removed. Why we discussed? Because in these patients there is deficiency of intrinsic factor. Obviously, how we are going to treat this patient? If you give oral supplementation, obviously it will not be absorbed because there is deficiency of intrinsic factor. So we have to give parenteral supplementation, and for how long? Lifelong. So what is the management here? The management of megaloblastic anemia, here we give lifelong parenteral supplementation. We have to give what? Lifelong. We give lifelong parenteral supplementation. Clear? So in these patients we give lifelong parenteral supplementation. Clear? So these are the metabolic complications of gastrectomy.